Welcome to our first Vaughan Grand Rounds of the year, the Infant and Family Experience in Neonatal Intensive Care, focusing on the management of acute procedural pain. I welcome you on behalf of the editorial team of Cochrane Neonatal, our large number of associate editors who keep the engine running, and in particular for our guest discussants today, who will be members of the editorial team, as well as our guest, Eric Rideout, a neonatologist and medical director in St. George Regional Hospital, who will focus on some of the issues regarding avoiding pain as opposed to treating pain. Our sponsors are the Vermont Oxford Network and our Institute for Evidence-Based Medicine. We also have unrestricted grant support to create and update reviews on the infant and family experience in neonatal intensive care provided by the Gerber Foundation. As a matter of disclosure, I am the Vice President of Vermont Oxford and Coordinating Editor of Cochrane Neonatal, but have no other relevant financial issues to disclose. I have to take a minute in this presentation to share with you the passing of a colleague who is very dear to us in New England at Dartmouth, at University of Vermont, and here at Vermont Oxford Network, and most assuredly throughout the nation and the world. Bill Edwards passed last month. He was a superb clinician, an excellent researcher, fantastic bedside teacher, an early parent advocate, a founding member of Vermont Oxford Network. But those of you may not know, also a boat builder, an avid tennis player, a moderately skilled player on the ukulele, a deeply devoted grandfather, and a good friend to many of us here at Vaughan, UVM, and Dartmouth. So, today's session is going to focus on pain. It's part of 3 sessions we hope to hold over the next 3 years. We would like to take a look at the evidence that informs our decision regarding the management of acute procedural pain, today's session, and later on, early next year, the management of longer-term pain and discomfort associated with mechanical ventilation or surgical procedures, and lastly, and perhaps most importantly, the impact of intensive care in terms of the environment and developmental care practices in improving infant development. So let's just start with acknowledging that stress and pain in the NICU is a very important factor. Although there have been significant strides towards decreasing mortality in preterm infants, many surviving infants experience significant developmental problems in both motor and intellectual development. The stressful environment of neonatal care is clearly a double-edged sword. It contributes to both our improved survival, but also creates many of our concerns regarding developmental outcome. The stresses inherent to neonatal intensive care include the need for frequent painful procedures, the pain associated with mechanical ventilation or surgical interventions, and the overall environment of neonatal intensive care, which is so vastly different from the environment that the infant experiences in utero. Painful procedures are really a perfect example of the stress inflicted on newborns while receiving intensive care. A study in 2003, which may seem dated, but we'll follow up on that, found that newborns in intensive care received an unbelievable 14 painful procedures per day, while almost 40% did not receive any analgesic therapy. In response to such studies, the Committee on Fetus and Newborn of the American Academy of Pediatrics has stated that preventing or minimizing pain in neonates should be a priority for neonatal caregivers and recommends that, and I quote, written guidelines based on existing and emerging evidence for a stepwise pain prevention and treatment plan, which would include judicious use of procedures, routine assessment of pain, and use of both pharmacologic and non-pharmacologic therapies for the prevention of pain are essential And those are the issues we're going to focus on in this session today. So first, let's go back to that issue about how big a problem is pain, with a focus on acute procedural pain. The fact is that reports from NICUs across the world have demonstrated that we have considerable room for development. Surveys from the early 2000s hit on several important points and gaps in best practices. First, they noted that staff underestimated the pain caused by procedures. They noted that pain assessment tools were only used in a minority of centers, that the respondents to their surveys reported that analgesia or comfort measures were not usually administered for most procedures. If these procedures were used, non-nutritive sucking was perhaps the most commonly used, while other methods of non-pharmacologic management were underutilized. And less than a third of individuals had received any training regarding the assessment and management of pain. Well, unfortunately, it's not all that different when we see surveys that are more current. Here's the EpiPain survey of 16 NICUs in and around Paris. In this, they found also an unbelievable number of procedures for infants who are in neonatal intensive care. They noted 16 heel stick procedures per neonate. And for these procedures, they noted that only 3/4 of them were performed with any analgesia. So clearly, the issue regarding pain, acute pain and procedural pain, still exists. So let's discuss the impact of pain. First, it's no longer for debate that preterm infants have the ability to experience pain. They have the necessary peripheral and central anatomical architecture required for pain sensation. The prevention and alleviation of pain in neonates, particularly in the preterms who receive so many of these procedures, is important not only because it is ethical, but also because exposure to repeated painful stimuli early in life is known to have short and long-term adverse sequelae. These sequelae include physiologic instability in the short term, but also longer-term issues like altered brain development and abnormal neurodevelopment, somatosensory, and stress response systems. Now, I don't want to skip over the fact, though, that the first most pressing issue, in fact, is our ethical obligation. As we say we'll do no harm, we have an obligation to the parents who put these infants under our care to minimize their pain and discomfort. It is part of our fundamental contract, and probably an obligation to each other, not to think that we are working in an environment that is busy inflicting pain on infants for no good reason. So let's take a look at the evidence around how we can minimize or treat pain in the NICU. Before we even look at the evidence, let's agree that perhaps the single most important thing we could do is to minimize the procedures themselves. There are no specific studies that look at ways to accomplish this, but there is work that is going on using fundamental cultural change, such as the POKE initiative from Dixie Regional Medical Center, which is a combination of unique cultural processes, a database that supports feedback, and has shown great promise. In this work that we'll hear more about in our flipped session, POKE eliminates over 10,000 procedures a year with savings that are close to $1 million. Clearly, this is core to our preventing our infants from having the deleterious effects of painful procedures. Now, when it comes to understanding babies' pain, they can't tell us a lot about it. They're not going to look at this Likert scale and tell us that this is moderately uncomfortable or severely uncomfortable. And so optimal pain management is difficult. It requires competent pain assessment. usually using multidimensional tools that include both physiologic and behavioral indicators because, as I noted, babies can't self-report. There are a large number of pain scales that have been developed, and they tend to involve physiologic indicators, including heart rate, respiratory rate, blood pressure, oxygen saturation, vagal tone, sweating, or even blood tests such as testing plasma cortisol or catecholamine concentration, and behavioral indicators such as facial expressions, body movements, and crying. It's important to note that for many of our babies, there are limitations in these scales inherent to the fact that many of them may be neurologically impaired or pharmacologically paralyzed and cannot be fully assessed for the reaction for the pain that they are undoubtedly experiencing. Here's just a picture showing some of the facial expressions, some of which are obvious, the wide, crying, horizontally stretched mouth, but others less so, such as the evaluation of the tense tongue or the forehead protrusion. Here's a list of some of the commonly used scales for neonatal pain assessment. If I gave you the full list, it would run several slides. But here are the ones that in particular have been used in randomized controlled trials. The PIP, the NIPS, the NFCS, the DAN, the Comfort Neo, and the NPAS have all been used, and I think it's important to note that they all combine aspects of physiologic and behavioral assessment, or at least most do, and that they have a variety of domains, and therefore their scoring will differ. For this purpose, and when I discuss some of the results of trials to follow, you'll see that sometimes when we're reporting the score, we just report the mean difference. But when we attempt to combine these scores, we use a standard mean difference. These tools have been relatively well tested for reliability and inter-observer characteristics. All right, so let's discuss some of the reviews that deal with optimal management of procedural pain. It's a long list here, and I must say that they are all limited by reporting on the acute responses to pain with very few, if any, longer-term outcomes, and they are all of either very low or low quality in their assessments because by definition, all of these procedures are unblinded, and all of these outcome measures, one could argue, are short-term surrogates. So let's start with a simple issue of how we obtain the blood, venipuncture versus heel lance. In this review by Shaw and Olson, they took a look at whether venipuncture or heel lance is less painful and more effective in blood sampling. There are 6 trials involving a small number of infants, 478 infants. And here we have the small number of studies that looked at heel lance in infants who did not receive a sweet tasting solution, venipuncture versus heel lance without any sweet tasting solution, and venipuncture versus heel lance in the context of giving the infants sweet tasting solutions. And what we see here is the scores that were measured are all slightly lower, and all of them in a conventional sense statistically lower, favoring venipuncture. The scores themselves are reported as standard mean differences, and these differences are relatively low. They're all less than 1 point on the scale. That said, they do consistently favor the use of venipuncture. Interestingly, the authors also looked at whether or not there was a need for more than one skin puncture, and to my surprise, they found that significantly fewer infants who received venipuncture needed to have a second skin puncture. The risk difference is minus 0.34, suggesting that you avoid one skin puncture for every child you attempt a venipuncture on for blood drawing as opposed to a heel stick. The authors concluded that venipuncture when performed by a skilled phlebotomist, appears to be the method of choice for blood sampling in term infants. But there's the rub. A skilled phlebotomist is not necessarily around the corner. Heel stick is a much easier procedure to perform, but clearly venipuncture in skilled hands is less painful. Prakash Shah and colleagues have reported on either breastfeeding or breast milk for procedural pain in newborn infants. They note that there are many ways that we try to prevent pain, but breast milk or breast milk feeding certainly is one that would have great merit given the inherent support of the infant-mother dyad. They found a large number of trials, but few that could be separately evaluated, and many that involved breastfeeding with the other series of interventions. So for today's session, I want to present to you the trials that purely looked at breastfeeding, the trials that looked at feeding breast milk, and here we have the results for the breastfeeding trials compared to no other intervention during a painful procedure. And you can see that in general, physiologic measures improved, duration of crying improved, the neonatal infant pain scale improved when breastfeeding the infant was compared to no intervention. And when breastfeeding was compared to just being held by mother, okay, even there, the breastfeeding itself led to improvement in the immediate physiologic state, heart rate, duration of crying, and in NIP scores. Breast milk wasn't quite as successful, but also just giving the substrate, mom's milk, without immediate breastfeeding, in one study decreased the heart rate. It did not affect duration of crying, but in two studies of 166 infants, did improve oxygen saturation and had a slight decrease that was not necessarily statistically significant regarding the neonatal pain scores. The authors conclude that moderate and low certainty evidence suggests that breastfeeding or supplemental breast milk, though less efficacious, likely reduce pain in newborns undergoing painful procedures as compared to no intervention or other interventions. They felt that it was low certainty evidence that there's no great difference between sucrose feedings. And given the fact that we want to support breastfeeding, really should be one of the interventions we strongly consider discussing with parents regarding soothing and calming babies during painful procedures. There is a very large review by Riddell and colleagues that is published by the Pain, Palliative, and Supportive Care Group that addresses a vast number of non-pharmacologic managements for infants or young children with procedural pain. For this discussion, I want to focus on two of those non-pharmacological interventions, non-nutritive sucking and facilitated tucking. And let's just start with what we mean by non-nutritive sucking. Non-nutritive sucking is a strategy where an object, a pacifier, or a non-lactating nipple, is placed into an infant's mouth to stimulate oral, tactile, and sucking behaviors during a painful event. Many of the studies that they report include other adjuvant non-pharmacologic care during non-nutritive sucking, but I'm going to focus just on the trials that evaluated non-nutritive sucking alone. There were 28 treatment arms, in part because several trials had multiple arms that involved different ways of offering non-nutritive sucking. And what they found was that there was a distinct decrease in pain reactivity, particularly in term infants, and improved immediate pain regulation in infants who received non-nutritive sucking. Again, it is worth noting that the differences in these scores are relatively low, frequently less than 1, and may represent only small improvements in the alleviation of pain. What about swaddling or facilitated tucking? Swaddling is when an infant is securely wrapped in a blanket to prevent the child's limbs from moving excessively. Facilitated tucking involves firmly containing the infant using a caregiver's hands or both head and lower limbs to maintain a folded-in position. And we're looking at both of these sort of restrictive efforts in reducing pain. 15 treatment arms are reported by Riddell and colleagues. And again, they find improvements in pain reactivity and immediate pain regulation. Fewer studies looked at term infants, only 1 in 42 infants, and also suggests improvements in pain reactivity associated with swaddling or tucking. Skin to skin is potentially a very important way to address comforting infants during these acute painful procedures. Skin to skin, also referred to as kangaroo care, has been studied in a large number of studies. In fact, there are 25 trials involving over 2,000 infants. But it's very limited about the data we can draw for the purposes of our analyses from this large body of literature. 5 studies looked at heart rate in skin to skin versus no treatment or control, and saw a decrease in heart rate both during the procedure, but not after the procedure. They saw decreases in crying in 2 studies, and they saw over time improvements in the premature infant pain profile over 60, 90, and 120 seconds. And so they do report meaningful differences with skin to skin. And in fact, when you look at the mean differences here, you can see that they are several scale points, suggesting in fact that they might be greater in effect than some of the other therapies we've looked at. The authors note that skin to skin appears to be effective as measured by composite pain indicators with both physiological and behavioral indicators, and independently using heart rate and crying time. Sucrose is also one of the best studied agents for alleviating procedural pain. In Stevens and colleagues' review, there are 74 included trials involving over 7,000 infants. Administration of oral sucrose with or without non-nutritive sucking is perhaps the most frequently studied non-pharmacologic intervention for procedural pain relief in newborns. What they found was that at a variety of concentrations of sucrose, it was very effective, in this case in decreasing duration of crying in infants. Topical anesthesia seems like an important and quite accessible way of decreasing needle-related pain, but in fact, there's a paucity of evidence addressing this. There are 8 trials involving 506 infants, and in fact, it was really almost impossible to combine these studies due to different outcome measures and methods of reporting. EMLA was used in 2 studies, amilocaine in 3. When EMLA was compared to placebo, in fact, there was only rather moderate effects on PIP scores, but NIP scores were reported by 2 studies as being lower. And importantly, there was no real difference in successful venipuncture attempts based on using topical anesthesia. Methocaine similarly had some small decreases in scores, but no effect regarding success of the procedure itself. The evidence regarding the effectiveness and safety of topical anesthesia is really inadequate to support any specific clinical recommendation. I'll wind up with 2 groups of studies that were recently reviewed by Matteo Bruscitini and his colleagues, and he will join us in the flip discussion. The first is non-opioid analgesics for procedural pain, an area that you think could be quite valuable, given the fact that some of the non-opioid analgesics, specifically non-steroidal anti-inflammatory drugs, are widely used. Unfortunately, the studies themselves are few. There are 2 trials involving 269 infants, and in fact, they use agents that really don't fit our question of interest. In this case, it's not just a procedural issue, but it's on laser photocoagulation, a much more invasive issue. And this was comparison of fentanyl versus ketamine. And so these are big time agents. But importantly, they note that the pain scores were higher in the infants receiving fentanyl as opposed to ketamine, at least opening the door to some interesting issues regarding pain control with these agents, but far from really advancing our understanding around minimal procedural pain. There's also a review by this group on opioids for procedural pain. The issue of using opioids, including morphine, fentanyl, remifentanil, et cetera, certainly has been considered. There are 13 trials involving 823 infants. The problem here, of course, is this seems like pretty big guns to pull out for treating what is, in fact, a short-term acute problem. For the opioids versus no treatment or placebo for procedural pain, there were significant decreases in scores in the handful of studies that report. But importantly, there were issues like increased apnea with a relative risk of 3.15, and other issues that give one pause before considering treatments like opioids. So in reality, there's really limited evidence regarding the use of opioids for procedural pain in newborn infants, whether it's compared to placebo, non-pharmacological interventions, other opioids or analgesics, or even what routes of administration might be best. It also is a real question whether or not these drugs are all too potent for these purposes, which are still relatively short and not as dangerous, perhaps, as the misuse of the opioids. So at this point in time, I'd like to flip the classroom and open up our discussion with a series of polls and comments by our guest discussants, Dr. Daniel Erert, Bill McGuire, Matteo Brusciatini, and Dr. Gotham, all of whom are active members of the Cochrane editorial team, as well as Eric Rideout, who I noted before has been instrumental in discussing how we can actually prevent doing these painful procedures as opposed to how we treat them. We'll hear a little bit more about where they think the evidence takes us, what are the best practices in their eyes, and we'll talk about what future research is needed, as well as poll you regarding what are your practices regarding minimizing and treating procedural pain. So we'll see you on the flip side. Thanks. So welcome. We're live now, and we're going to flip this discussion and try to address some of the issues and questions that are brought up from the evidence you previously heard. Again, we're sponsored from Vaughan and our growing Institute for Evidence-Based Practice. And this was supported by an unrestricted grant from the Gerber Foundation. You heard who we have from our editorial team: Daniel Erert, Bill McGuire, Matteo Brusciatini, and Suresh Gotham. We're also very pleased to welcome Eric Rideout to talk about what I think will prove to be some of the most interesting discussions of how we can actually avoid these procedures. So we'd like to get you guys to participate to some degree by using Poll Everywhere. And you can also type your questions into the chat box. We'll be monitoring that and hopefully integrating that into the discussion that we're having. For using Poll Everywhere, here are the instructions. Some of you may be familiar with it already. You can open your web browser and type in pollev.com/Vermont VT Oxford. You could download the app Poll Everywhere on your phone and then open and select the joint presentation and type in VT Oxford, or text VT Oxford to 22333. Hopefully while you're doing that, let's test how we're doing. We'd really like to see more participation. So let's just test. Did you make any New Year's resolution this year? And you guys are not like me, because I would be answering D. Yes, I made them, but I've already broken them. So yeah, there we go. 2% of you are like me. So great, but please do text in. The instructions will be on the top of every poll slide, and let's get to work thinking about this. So as you know, our topic is pain, and we're going to take a look at some very basic issues around what we might consider the best practices. We're going to poll and discuss the impact of pain on neonates, guidelines for pain management, policies and procedures to minimize painful events, assessment of pain, and treatment of pain. Let me start with a philosophical question, and that is whether or not you agree with the following statement. The prevention and alleviation of pain in neonates, particularly preterm infants, is important not only because it is ethical, but also because exposure to repeated painful stimuli early in life is known to have short and long-term sequelae. I was counting on seeing 100% here. If you are of my age, in the beginning of your training, you might not have answered it that way. But I think our understanding has grown tremendously regarding both the short and long-term adverse sequelae. And I don't know if anyone from the panel has any comments about the meaning of this, but I think the philosophical underpinnings of the fact that this is an important issue to address in our newborns and their families is a sensibility that now, as the poll showed, is universally accepted. All right, so let's move to the issue of preventing pain itself. The question here is whether your unit has policies or guidelines in place that are geared towards minimizing painful procedures. And that's great. I'm glad to see the poll coming in that says the majority have addressed this issue through guidelines and policy. But I'm also glad for the honesty that almost 30% don't have such policies. And on that note, I'd like to have Eric Rideout share with us more about the important work that he's doing and supporting regarding POC. So if I could turn the platform over to Eric and tell us about this exciting work.
Sure, thank you. First off, thank you for the opportunity, and want to say what a blessing it is and an honor to be able to discuss what we're truly passionate about, that we are blessed each day to show up and get to serve those that are doing this incredible work at the bedside, get to be part of these babies' lives, and seek to make it impossible for the folks at the bedside to fail, where the baby gets hurt, the family, the caregiver, or the organization. I'm going to talk a little bit about the last 15-year journey we've been on, and that we continue each day to seek to provide better care tomorrow than today. And really what that boils down to is that we show up every single day seeking to add value to each other. And when we do that, we flatten the hierarchy. By adding value, we're demonstrating the mutual respect and love we have for each other, and that creates this culture that effectively insulates the baby from care that's not going to add value. Simon Sinek says, start with why. Well, our why is that we have a passionate belief that babies and caregivers deserve to experience care delivery free from harm. Not just serious safety events, collapses, and those sorts of things. That's a passive byproduct of what we do. It's that the baby never should experience care that doesn't add value. And the way we do that is by doing this deep cultural work, by investing in each other, by pouring value into folks, by leveraging the genius at the bedside, and we'll talk about that, and ultimately through critical thinking, identify care that's trying to get to the baby and not let it happen. And so the long and short of that is that babies should experience care that's for them and never to them. And so we call that ecosystem of care or that culture POKE. And historically, it stood for prevent pain and organisms from skin and catheter entry. That's what POKEs meant. It has a much broader definition now, and there's the two here. The first is a POKE is any clinical intervention that has the potential to harm the patient or fails to add value. And we should seek to measure everyone trying to get to the baby. That becomes the voice of the baby. And up in the right-hand corner is a little girlfriend of mine named Macy, 23 weeks, born 15 years ago. And she's the first baby we measured every single POKE on, and she experienced over 1,300 during her stay. And this is before we really got good at doing this. Now, the vast majority of those weren't painful, but way too many of them were over 200. And in terms of why this matters and that every single POKE should be assessed if it's going to add value or not, she just texted me her grades yesterday. She's getting A's in integrated science, life skills, a B in beginner computer programming, and she's struggling in language arts, Utah studies, and college awareness. Is that a function of what care she experienced? Maybe. She deserved to experience better care than we provided. And so every single day, she's charged us with developing a team-based, patient-centered ecosystem where all are empowered to actively contribute to surface safety concerns, to experience deep respect and be genuinely loved at work, relentlessly eliminate waste, and help patients, families, and babies, caregivers, feel safe, valued, and loved. Roger, can I get the second slide, please? So in chatting with Macy, voice of baby or voice of Macy becomes critical because we're really there to serve them. And actually, I see myself as being the leader that's serving the team, and the team is the one protecting the baby from my decisions. So the baby is in the center of everything we do. The only individual in the room that outranks everybody is the baby. Okay? And so the baby's only going to experience care that adds value. And the way we do that is by surrounding the baby with a force field, this mesosystem of the team, where we all work together in a collaborative fashion to only allow care reach through that's going to add value and advance the cause of wellness. Now, leadership from an accountability standpoint and from a position of humility allows this. We then use huddles and other strategies to leverage and maximize and cultivate a culture of psychological safety so folks do speak up, and then harm, ego, excess care, burnout, and POKEs don't stand a chance. All this done on the firm foundation of a just culture. Now, we have 6 principles that sort of motivate this. The first is nobody wants to experience a POKE. Every POKE matters, and there should be a thoughtful discussion about eliminating it or bias towards eliminating it. Every POKE should add value and should be beautifully documented in the medical record about why it's going to happen, and then once it happens, how it drove therapeutic modification. If not, it shouldn't happen. What the patient or baby needs is more important than what you want. Curiosity, nope. Because I want it, nope. Because I'm fearful, nope. No member of the care team is more important than any other member of the care team. And again, the baby outranks everybody. And finally, every member of the care team deserves to experience mutual trust, deep respect, will surface safety concerns, and will be accountable for the care they provide. Just culture. So Roger, let's go back to the prior slide, please. So in terms of how we did this, truly thoughtful care, looking to the evidence if it exists, and we find that the vast majority of care that most patients, not just in the newborn ICU, but across all care arena, isn't evidence-based. Maybe 30 or 40% is. That means the rest of it isn't evidence-based, and doesn't mean it's wrong. It just should be challenged before it reaches the patient. I call this care TWIT care, or the way I trained care. So this is care that we might have learned in fellowship, and that our mentor, well, we always check sodiums on Monday, and we get in the rut of doing that without ever challenging it, and that the baby has to experience that care even if it isn't advancing wellness, and it might actually be causing harm. And so we need to measure those things and track them before they get to the baby. Pretest probability. What's the likelihood of this result actually changing what we're going to be doing beyond what we already know? Voice of the baby. So the way we do that is we surface the care experience from the electronic medical record. Turns out that when you ask folks how often they think they're touching or poking a baby, they vastly underestimate it. We surfaced with crystal clear accuracy every time a baby had something done, and we found that one poke for a venipuncture actually was 6 attempts. And each one of those pokes it potentially caused the downstream effects of pain, but also decreased skin and tissue integrity, and then would basically have a ripple effect out into history where it would echo back as a late onset infection, and then feeding intolerance and other things that would increase their cost of care, but most importantly, damage them and have her sending me worse grades. It's going to always be team-based, not just individual-based. Teams and leveraging the team is the way we do this successfully, and it has to add value. And there's lots of descriptions in the literature about what value is. We look to the patient to say, is this what you want to advance your cause of wellness? And by having the team think that way, including the parents, we're able to accomplish that. And so we utilize culture. We love our folks. We're blessed each day to get to serve them and seek to make it impossible for them to fail at the bedside. And that's what leadership really is. It's influence and adding value. And surfacing the data with a tool from our EMR Cerner. It also works with Epic. So on the bottom, this is some of the results from our NICU. Massive reduction in pokes from baseline. Reductions in length of stay. We stopped hurting them. They went home sooner. Who knew? And in intensive care unit, less intensive care was better. Collapses, we basically are never going to have another one. Now, the next one wants to happen tomorrow, but we're so preoccupied with failure, we're not going to let it happen. The last one was over 4,000 days ago. We have very high Press Ganey engagement and effectively no turnover other than folks that are blessed to retire. Folks want to continue to work here because they go home each day knowing their opinion matters. We laterally deployed this across our multi-hospital system in Utah. In the first year of implementation, 150,000 non-value-added interventions that otherwise would have reached MACI were eliminated, roughly 50% reduction. You can see there, dollars that were budgeted weren't spent, and the net impact on revenue was massive. And this ends up being how we bless back the community by dropping the cost of care, and more importantly, by having these babies get to live the healthiest lives possible and send me grades that are even better. Thanks.
Eric, thank you so much.
Yes, sir.
As you know, our focus is a lot on what we know about the interventions, but your core point about the culture and our commitment not to intervene for our own purposes, traditions, whatever, is clearly an overarching and much more important concern than some of the small issues around what we can do to minimize it once we make these choices. I am confident that people are going to want to reach out to you after this to understand more about this procedure. And so I hope you don't mind if we share email or websites with participants, because to me, this is very motivating as we really contemplate how we want to address pain in our newborns.
Yes, sir. Welcome it. Thank you.
Thank you. So let's get back to some simple questions. I suppose you could argue if we failed Eric's ideas that we should not be drawing this in the first place. But how do you draw blood? Do you routinely use venipuncture or heel stick? And I can see here that the vast majority is heel stick. So let me just turn this over to Bill McGuire for some comments about the approach to the procedure itself.
You made the point earlier about the availability of skilled practitioners for venesection and the importance of the reliability of the blood sample for measuring for example, the plasma sodium, the potassium particularly. Well, so not just the pain or the measured pain is important, but the particular use for the sample. So perhaps for a hematocrit, heel prick might be fine, but if you're really worried about the potassium in a baby who's had an acute kidney injury, you might choose to go for the venesection. Of course, the big issue, particularly with preterm infants, is preservation of blood vessels. And we know that the smaller the infant, the more critical that factor becomes. So it's a complex thing. It's not just this one issue of pain score. It's the intent of the procedure. But I think Eric's point about why are we doing these blood tests and the culture of routine blood tests, weekly blood tests. I think's disappearing now. Certainly in the UK, my experience, people are doing less and less of that. But post-extubation blood gases, etc., frequent blood gases, again, trying to reduce those is important, is as important as thinking about the route of sampling.
Your point, though, about the fact that there's more than just the procedure itself, that for the preterm babies, puncturing veins may compromise future care, is something to consider as well before adopting this. All right, so let's go to this issue about whether or not you have policies and guidelines in place that address the assessment of pain. And by that, I mean either standard scoring or other assessments. And it seems like the vast majority of people do have such policies in place. Clearly, it is part of the recommendations and guidelines from most organizations, and that one of the issues there is what pain scales do you use? And this would be for, the vast majority of patients. Okay, interesting. So there's some heterogeneity there. And maybe if I can call on Matteo Brusciatini to talk a little bit about his work looking at these various scales and their reliability.
Thank you, Roger. It's also a very important topic, the choice of the pain scale. And of course, there are at least 65 published pain scales in infants. And definitely we don't need so many, and most of them lack any type of validation. So it's very important to choose those pain scales which have been to have some validity and reliability. For example, with the COSMIN, it is possible to assess if not only for pain, if any way to measure outcomes are reliable or not. And we conducted a few years ago, together with Professor Mats Eriksson, a systematic review including 29,000 infants in 300 studies, where neonatal babies in randomized trial were assessed for pain. And there is such a variety of different pain scales. But it's very important to be aware of which type of baby and which type of pain. For example, today we're speaking about procedural pain, which is very different than postoperative pain or prolonged pain. And different type of pain require different type of pain scales, but also the age of the infant. So some pain scales are valid in preterm, others in term, and others in both. There are only 4 pain scales which have enough quality to be used for procedural pain in preterm infants. And there is a very useful systematic review done by the group of Giordano, published in JAMA Pediatrics, reporting for which pain scales might be used for that specific type of pain and for that type of infant. Of course, it's very important then that the staff is trained, first of all, to assess pain, to choose the right pain scale for that type of pain assessment. So might be that in the same NICU, one pain scale might not be enough if the infant is exposed to different pain stimuli.
Thank you, Matteo. Of course, I've been discussing the use of the pain scale simply as an outcome from trials with the single procedural pain. The scales are obviously more important in patients with repeated painful procedures or post-operatively, where a lot of it is about ongoing assessment, communication with the family and nurses, etc. So how many people, if you do use scales, receive formal training in the use of pain scales? And fantastic, again, although the majority have some formal training, it appears to be something of a quality issue for improvement. Matteo, you have any thoughts about formal training?
Yeah, well, it depends also in which part of the world we are, because pay scales needs also to be validated and also to be checked for cultural validity. So some pay scale might be valid in some contexts and not in others. So it's important where we are based, and here it's an international context, so it's important to be aware of that. And then I think that also during this webinar, that important topics has been already been suggested, for example, to minimize the painful procedure, of course, and then also that it's not enough to measure with the best pain scale, but then also to have policies on how to manage, to treat, and prevent the pain in these babies.
Thanks, Matteo. I had jumped to this slide, which gets to the issue of policies and guidelines, specifically addressing what treatments you use. And again, although the majority have addressed this, there's still room for people to really think about protocolizing this aspect of care. If in fact you have an approach, what is your sort of first go-to? I recognize that people may use many of this, but what's sort of your first line treatment for non-pharmacologic approaches to procedural pain? So it's interesting to me. I'd be curious what some of the other editors think, but you know, the issue of breastfeeding and breast milk is apparently underutilized. I don't know what some of the other editors' thoughts are on that.
This is Gautam. It seems like a underutilized opportunity that we should be trying to close the gap on, especially considering the evidence that's favorable.
I would agree. And interestingly, though, it sort of goes into our last poll question, which is, do you have policies and guidelines to communicate your approach to pain management that includes parents in the assessment? And in this case, if we're talking about breastfeeding, even the alleviation of pain in their baby.
Yeah,
So,
I also wonder how often we include this in our counseling about breastfeeding and breastfeeding support with parents to encourage them to pump and supply breast milk. I bet you we're not including it.
I agree, Gotham. It's another gold star for breastfeeding. I would recognize that, you know, different relationships with different families and the comfort level of experiencing their infant's pain will vary. But if this becomes the routine, it seems to have great appeal. And this question is very interesting. This is a place also for improvement. I don't know if
although Ruth is chatting in an important point that sometimes mothers will refuse to do breastfeeding during a painful procedure. They don't want the baby to develop an association between pain and breastfeeding.
Yeah, I do think it's complicated. I agree. But for example, supplying breast milk as opposed to sucrose, where they are both fairly adequate, is just yet another message to parents that this is really important and this is part of our approach and contract, that all this sort of more natural and supportive care might be better. In either case, it's interesting to see that people don't have a formal way of communicating or thought about communicate what are they doing about pain, what their approach is to pain management, and how parents can feedback about pain. That seems to be a meaningful gap. I don't know if any of the other editors, Danielle, you have any?
Yeah, I'd love to jump in. And I think, Gotham, you made a great point of why this really needs to be viewed that parents are partners. You know, we should ask the mother, would she like to hold the baby and provide, you know, breast milk during this procedure or not? And really, you know, truly value the family as partners in care. To bring this back full circle to one of your very first slides, Roger, I am so lucky to have been Bill Edwards' medical student. And so this question really makes me think about him quite a bit.
Yeah.
It really was his passion for family-centered care that opened my eyes to this amazing and amazingly different field of neonatal medicine, and really, his passion helped to solidify my career path. And I think, this slide in particular, in addition to some of the elements we talked about in POPE, were to me the take-home points of this talk. First, we really have to minimize painful procedures, but then secondly, really just reminding us all, any type of provider, of what our responsibility is to the family, and really honoring and respecting them as partners in care, and emphasizing, their role in both assessing and alleviating the pain. So it looks like we have a lot of work to do. So we'll have more to discuss, I think, on coming webinars, and the chat is robust. I think we'll have some resources to share, but it looks like we have a lot of good work ahead together.
That's perfect, Danielle. I agree. The two major points, or three major points that come home, is how limited our treatment approaches are, how avoidance is the best policy, and we need to partner with parents regarding the environment we've placed their baby in, and our commitment to decreasing pain, and how they want to report and approach it with us as well. So again, just to sum up, many of you have written guidelines about some of the specifics like scoring and treatment, but few have really addressed a cultural change about decreasing the procedures themselves, or getting parents involved in this entire process. And so, like you were saying, Danielle, we've got work to do. I'll end up just openly. Gotham, you have a couple of comments before we finish?
Yes, quickly, I think we discussed broadly non-pharmacologic therapies and pharmacologic therapies. With the pharmacologic therapies, the real question is the trade-offs between the benefits of reducing or suppressing pain versus the risks of the medications. And we need to walk a fine line between those two, because I don't know, many of you might remember 20 years ago, there was a big push to use pain as the fifth vital sign. And there is concern now that somehow, I'm talking about all age groups, not neonates, there is concern that push actually led to the opioid epidemic. And the AMA actually withdrew the use of the fifth vital sign being pain because of that concern. So managing risks versus benefits, especially with pharmacologic therapies, is important. I think there's widespread use of dexmedetomidine as an analgesic, and I'm really concerned about that because the evidence for that is pretty scant, and we need to ride the brakes on that. And it's also interesting that pain or the number of skin punctures is not measured as a quality indicator in many databases, and perhaps it should be. This session is making me wonder why we don't track that routinely. It's such an important metric.
Eric does. Thank you, Gotham. In our future session, when we talk about the discomforts and pain associated with intensive care, not just procedural pain, but being on a ventilator or being post-operative, some of those points you made, Gotham, really hold sway about how much harm are we causing, especially with chronic use of some of the stronger medications. So I'll draw things to a close here. Invite you to join us through the year for some of our future programs. Coming up next will be some work about plans for safe care in neonatal abstinence syndrome from Stephen Patrick. And we'll be looking at aspects of the evidence later in the year regarding CPAP, particularly in diverse settings, both high, low, and middle income settings. And lastly, we'll be talking about translating evidence into practice regarding care of the developing brain. So thank you very much for joining us, and we'll see you later this year.